Hi everyone. Yeah, thank you for joining. And I would like to welcome you all to our keynote speech for this year's Drexel Emerging Graduate Scholar Conference. And yeah, before I introduce our keynote speaker this year, I just want to say, if you have any question to our keynote speaker, please use the Q&A box, and we'll deliver all the questions to our keynote speaker at the end of the session, and he will be answering your question. So first of all, I would like to introduce you all our keynote speaker for this year's Drexel Emerging Graduate Scholar Conference, Dr. Joseph Amon. Professor Joe Amon is the Director of Office of Global Health and a clinical professor in the Department of Community Health and Prevention at the Drexel's Dornsife School of Public Health. Following his doctoral work in molecular parasitology, he served as an Epidemic Intelligence Service Officer at the Center for Disease Control and Prevention and led the Health and Human Rights Division at Human Rights Watch. He has held visiting or adjunct academic appointments with Pace School of International Affairs, Sciences PO, Uniform Services University, Princeton, Columbia, and Johns Hopkins Universities, as well as the Institute for Advanced Studies. His research uses mixed method to examine the impact of political determinants, such as laws and their enforcement on health. This work has examined the impact of discrimination on access to prevention and treatment, censorship, and the denial of health information, arbitrary detention, and the role of civil society in the response to infectious disease outbreaks, and the environmental health threats. He has published his work in academic journals such as The Lancet and New England Journal of Medicine, and contributed opinion pieces to press outlets from Foreign Affairs to CNN to the Bangkok Post and the Washington Blade. Dr. Amon's work is the epitome of a conference theme this year, which is research to tackle emerging challenges. And we are honored to have him speak in DEX 2021. So without further ado, I would like to welcome Dr. Amon to take it from here. Thank you.
Thank you very much. I'm delighted to be here. I will share my screen and get my slides up, and we'll be good to go. Okay, so the title of my talk today is No Magic Bullets, the importance of community-led approaches and human rights in the response to global health challenges. And I put no in parentheses here a little bit to play with the concept of magic bullets and, what are magic bullets, and do we have magic bullets, and, how magical are they? And partly because I was a little bit uncertain and sort of thinking through this topic. There's been enormous successes in global health. Polio, which used to be endemic in 300 countries around the world, is now down to being present in 3. Measles deaths have decreased by 80% in the last 5-6 years. There have been similar reductions in diphtheria and whooping cough and tetanus and meningitis. There's age-old, ancient diseases like trachoma and river blindness, which are on their way to elimination. And there's diseases like guinea worm, which I'll talk about, which are down to just a handful of cases. But I wanted to also give you a little bit of a sense of my journey, my intellectual journey, my career pathway. And I labeled it a sort of alternative bio to kind of emphasize that it's not been a straight path, and it's been influenced by certain things. And one of them was, as an undergraduate, reading the book And the Band Played On, which was about the onset of the HIV epidemic and pandemic, first in the US. And it really had sort of alternating chapters between the role of scientists and epidemiologists trying to understand this newly emerging viral disease, and the role of communities in terms of responding to it and seeing the impact of it and seeing the stigma and discrimination they faced with it. And so what I have here is both the cover of the book, but also a square from the AIDS quilt, which was a community response to memorialize, but also to spread attention to the growing pandemic. And another book that really influenced me was a book called Rats, Lice, and History, a much, much older book by a scientist named Hans Zinser, which looked at specifically at typhus. And this book was told in a way about hunting down and trying to understand infectious diseases, and was written in a period where it was very florid in terms of its language. So protozoa, viruses, infected fleas, lice, ticks, mosquitoes, and bedbugs will always lurk in the shadows, ready to pounce when neglect, poverty, famine, or war lets down the defenses. And this, to me, symbolizes the fact that even when we think we have magic bullets, things can disrupt the magic. Things can cause these diseases to come back. And we're seeing that, and we've seen that now in the context of wars and civil strife. We've seen it in the context of climate change, in the context of migration and refugees, in the context of urbanization across the world, that there's new opportunities for diseases that were once vanquished by seeming magic bullets to rebound and to become problems again. So after my undergraduate experience, I did a master's in public health in parasitology at Tulane University School of Public Health. And then from there, I went into the Peace Corps and worked on a disease called guinea worm disease, which you can see in this picture here, and then a picture of me with my host family in the country of Togo. And in a lot of ways, the campaign to eradicate guinea worm, which was led and sort of spearheaded by former President Jimmy Carter, is about looking for a magic bullet. It's about being only the second disease that we will ever be able to eradicate fully. And it's a disease of antiquity. It's a disease that was widespread and is now down to only a dozen or so cases in humans worldwide. But it's a disease that was targeted for eradication by the year 2000, and clearly we're beyond the success date that we had hoped for, and still struggling to find ways to get to the finish line. So after my Peace Corps experience, I started working in HIV, and this was partly influenced by the fact that I saw some of the first cases of HIV in Togo, and I saw the inability for communities to understand, and for the medical community even, to know how to respond to it. There was a person who worked who lived in a village where I worked, and he came to me and said that he was worried. He had been sick. He had been living outside of the country and had come back when he had gotten sick. He had gone to get an HIV test at the local hospital, and he had returned for his results several times and had been told that the result wasn't available. And he asked me if there was any way I could help him. And I went to the hospital where I knew the physicians and I knew the medical director, and I asked them what was the delay in the cause of his result. And they said that they weren't sure that he would be able to hear the result, that he'd be able to support the result. And this spoke to the amount of stigma that existed at the time, and that lack of preparation of medical personnel to counsel and to provide information on HIV to people. And that it moved me, and it caused me to really want to look closely at HIV globally. And so I began working for a USAID funded project and doing research that was largely looking at building the capacity of local organizations, local communities, and designing programs and evaluating them to see if they were working. But at the same time, I was still interested in parasitology. And in this column is some of the articles that I worked on with a stint at the National Institutes for Health and with the Walter Reed Army Institute of Research, looking at parasitic diseases, two of them related to malaria, one looking specifically in Western Kenya. And so I was still trying to understand where the magic bullets were and where my interests were between communities and lab-based molecular parasitology. And after I finished my PhD in molecular epidemiology of malaria, I went to the Centers for Disease Control as an epidemiologist and as a member of the Epidemic Intelligence Service, which was the group that was highlighted in the book and the band played on as being disease detectives on the hunt for disease outbreaks to understand them better. And one of the things that I worked on was a study of a big hepatitis A outbreak that killed several people and sickened thousands. And using molecular tools, we were able to identify a cluster of related cases, that these weren't incidental cases of hepatitis A. And we were also able to trace the green onions from restaurant supply records to facilities or farms in northern Mexico where green onions were growing and being packed with ice that was made on site from a water source that was downstream from housing for the farm workers. And you saw this issue of what is global and what is local. You have a disease occurring in the US that's coming from imported produce. We're trying to tackle disease burdens in the US, but to do that, perhaps we need to look overseas and think about ensuring access to safe water, ensuring that farm workers are themselves vaccinated from hepatitis A and not getting sick and not then contaminating produce that becomes part of the problem in the US. So this was also a issue of communities and of technologies and thinking about what's the most effective approach and how do we solve that. Another project that I worked on was on hepatitis A vaccination rates in children in the US. And this project and another one related to hepatitis C virus really dove into the issue of inequalities and looked at racial differences. And in the case of the hepatitis A vaccination, there was a successful policy that prioritized communities that were at higher risk for hepatitis A, that lived in urban areas, who were Hispanic, American Indian, or Alaskan Native, or born to women with less education. And that led them to be at less, or to be at higher probability of having been vaccinated. So a successful way to address health inequalities. On the right, there was a more challenging study that was done in 4 cities in the US, looking at hepatitis C rates according to the amount of time people have been using injecting drugs, and then looking at that shift over time and seeing wildly variable rates of decline or stagnation and lack of decline based upon race and based upon city. And that opened up a lot of questions about why. What are the policies that are shaping risk in these different specific settings? And how are we failing to look at broader factors like housing stability for a population that's very vulnerable here? So this brought about this kind of question of what kind of epidemiologist I was and what kind of epidemiologist I wanted to be. And there was a study, or a commentary really, written by a epidemiologist at Columbia University School of Public Health, who was from South Africa and who was also politically active, that posed the question, should the epidemiologist be a social scientist or a molecular biologist? And it, the question spoke to me. And the answer was that an epidemiologist should be both and neither. And it talked really about how epidemiology as a discipline needs to work from sort of molecules to society and understand health problems in that way. And it gave me a lot of food for thought, but it ultimately left me a little bit uncertain of, how do you capture everything? How do you do multi-level epidemiology and still retain, the important voices of communities, their values, their prioritization of what their health risks are, as well as use the tools of science to find answers and to find solutions. And as part of that thinking, and a part of thinking about what the next step for me in my career was, I decided to really look at the issue of political epidemiology. And this came about as part of my transition to working with Human Rights Watch. And it really was an attempt to bring together different work that I had done and hone in and focus on how laws, policies, and their enforcement influence vulnerability to health, both in terms of protection and health protection efforts, but also in terms of access to healthcare. And one of the areas that I was still very interested in was HIV. So I continued to work on this issue and to look at it particularly in terms of populations that were most vulnerable to HIV, including racialized minorities and criminalized populations like drug users, sex workers, and migrants. who face high rates of discrimination, police harassment, arrest, and have difficult access to justice. And so it was a way to try and use epidemiology to look at individual levels at behaviors, but to look at a broader structural environment that shapes those behaviors. So for example, people who use drugs who are in need of clean syringes or opiate substitution therapy have certain behaviors that can be tied to risk of HIV, but those behaviors are structured by whether there are police waiting outside of a needle exchange site to arrest people, to bring them in, to charge them with possession of needles or possession of minute amounts of drugs in the needles that they're seeking to exchange. The same thing with sex workers and violence against sex workers, or the ways in which sex workers to evade police, to evade arrest, to evade abuse, might have to take on additional risk to meet clients to earn money. So the question that I was really posing was, how well does epidemiology address what are political determinants of health? And at Human Rights Watch, I did a number of different reports with colleagues there related to HIV, related to the environment and environmental health exposures like lead and mercury, also related to clean water and drug dependency treatment, access for people with disabilities to health services for migrants. And these projects together, I want to share with you a few examples of. So in one of the first projects I worked on, there was the issue of hospitals in the country of Burundi in Central Africa detaining patients who couldn't pay their bill. So they would hold them in the hospital. They would stop giving them medicine. They would stop giving them a bed to sleep on. They would be held in a room. They wouldn't get food. Family members could bring them food until their bills were paid. And so we looked at this phenomenon in a research study in 6 hospitals where we just basically came to the hospitals and asked if they were holding any patients who hadn't paid their bills. We did interviews with those patients. We interviewed hospital officials also to ask them, phenomenon around why they were holding patients. And we also looked at the amount of the bills over several years. And one of the things that we found was that one of the main reasons that people were being held was because they had had a cesarean section, which caused the bill to be quite expensive. And so here was a problem that was both impacting directly those who were being held, but also impacting people who were afraid to come to the hospital, especially pregnant women who are afraid to come to the hospital and fear having an expensive bill and then losing their liberty. Another project that we looked at was the availability of palliative medicine and morphine in particular, which is a very inexpensive generic drug across different countries in the world. And so some of this was desk research. In order to get a license to import morphine from the International Narcotics Control Board, you have to estimate how much morphine you need, you have to request it, and you have to purchase it and bring it into the country. And what we found was that by looking at the number of people who were estimated to die of cancer every year and the number of people who were estimated to die of AIDS, multiplying that by the percentage that would be expected to experience moderate to severe pain, we could get an estimate of how many people might need a drug like morphine. There are very few other cheap palliative drugs that are as effective, and how much morphine was actually imported, and we could compare those. So for example, the first line here is Benin. We estimated that the number of individuals expected to need pain treatment was over 15,000, and the number of individuals for which morphine was imported would be able to provide for 83. So 0.5% of those who would be expected to be in severe or moderate pain would receive it. And we did a number of in-depth studies in about a dozen countries around the world to understand better the specific barriers to morphine and also the practices of medical professionals. And some of the things that we found in this work is that legal barriers could be present in Controlled Substances Acts and import and drug procurement regulations. They could be at various levels: international, federal, state, municipal. And some of the specific laws included that doctors had to submit a urine test to prescribe, which sometimes meant that doctors didn't want to get authorization to prescribe because it was a hassle. They could be found criminally responsible if the morphine was misused. And so doctors also sometimes wouldn't want to get authorized. Only certain specialties would be authorized to prescribe morphine. So oncologists might be able to prescribe it. But if you had extrapulmonary TB and it was extremely painful, you weren't seeing an oncologist, and so you didn't have an ability to get a prescription. Sometimes special prescription forms were required that were hard to get. In some countries, multiple physicians were required to sign the prescription, which was very challenging in countries that had few physicians. Sometimes there were limited dose or time limits. And if the only source of morphine was in the capital and you lived far from it and you could only get a 3-day supply, that meant effectively you weren't likely to travel for hours in an uncomfortable bus or van to renew your supply every 3 days. So this was another area where we were looking broadly at health, at quality of life, and looking at where the barriers were and who was most vulnerable. Another area was looking at the issue of prisoner health in sub-Saharan Africa. And I am emphasizing these because they're all gaps that we identified, areas where data was either not available or where the issue itself wasn't prioritized. It was overlooked. It was not seen within the kind of global health's mandate or within their agenda. And within the context of HIV and TB, both of these things are major concerns globally. They're major funding donors that provide funding for it. But people in prisons were being completely neglected. And in many countries, there was just simply no data on how many people in these facilities were having HIV or TB. We did one study, for example, in Zambia, another in Uganda, another in Sudan. But you could see that the conditions were very amenable to tuberculosis. There were massive overcrowding, people sleeping on top of each other, very limited circulation or windows. There was also incredibly inadequate food. This was a project that we did in partnership with an organization that was made up of former prisoners, as well as a regional coalition that worked on HIV and TB in Southern and East Africa. And we worked on it in partnership with the Zambian prison medical director, who was very aware of how much change was needed. It was a mixed method study. We combined in-depth interviews with prisoners, as well as interviews with prison officers and facility assessments and legal and policy analysis. What we found wasn't tremendously surprising. There was mass overcrowding, malnutrition, sexual and physical violence was occurring, and there was really limited HIV or TB prevention testing or treatment programs in place. But these findings were data that wasn't there before, and that wasn't forcing the government to pay attention to this issue or this problem, nor forcing donors to really look hard at why this was a population that was being excluded. And one of the arguments that we made was that, people in prison leave prison every day. And so there is a connection between communities and prisons that doesn't allow you to sort of say, well, the prison community is over there, we'll get to them later, or we won't address them at all. We're going to focus on communities. And the same is true for prison officials. And this issue has been very much the case with the current COVID pandemic too, where in the US, prisons have been more than 5 times more likely, or people in prisons have been more than 5 times more likely to become infected with COVID than people outside of prisons. There's no transparency of data on how many prison and jail corrections officers have become infected. There's very limited steps that have been taken to ensure they're able to socially distance. to ensure that they have proper PPE. And that involves people both in traditional prisons, but also in immigration detention centers where people are being held for administrative violations leading to their deportations. So people are being held in an extremely high-risk environment when they may have been living in the community for many, many years because of a change in policies. And I also wanted to point out that this is a very, very old problem. In 1903, this article in the New York Times referred to the average prison as a death trap. And those exact words were used by the prison medical director in Zambia as well, acknowledging that the risk of TB was so high. And in South Africa, a study was done of a prison which found that there was a 98% chance of TB acquisition if you had stayed in the prison for 1 year. So these are the many research reports that I wrote with colleagues on issues around different kinds of detention settings. So a number on straight prisons in sub-Saharan Africa, a number on drug detention centers where drug users were being held under the name of rehabilitation and treatment, but in reality, strictly as punishment in Asia. And then finally, on the other side is some literature surveys done looking at this over a broad population, including with the issue of COVID. I wanted to also highlight a current piece of research I'm doing with my colleague, Professor Nina Sun in the School of Public Health, which is looking at programs that are specifically trying to address human rights issues related to HIV and TB. This is a 20-country study. The Global Fund has funded more than $40 million to specific kind of programs addressing stigma and discrimination, the training of health workers in ethics and human rights, sensitizing lawmakers and police, legal literacy, which is training communities to know their rights and be able to defend their rights against discrimination and against other kinds of abuses. Legal services, which is allowing some measure of accountability where people are able to make a complaint, for example, if they're turned away from accessing healthcare or turned away from a prevention program. Legal reforms, looking at the ways in which laws can be changed to end the criminalization of certain populations, and addressing gender discrimination and violence as well. So you can see here, you don't have to look too closely, but there's a range of improvements that have been made in these 3 countries that I'm highlighting. Some, very large investment leading to a big change in the scale of these programs and their ability to have an impact. Some that are much harder, and as you can imagine, legal reform takes a long time, but training health workers and police can be implemented quite quickly and quite rapidly. So looking at the issue of human rights and epidemics specifically, I've looked and I've worked on a number of different epidemics and pandemics, including SARS, H1N1, Ebola, and now COVID. And oftentimes the typical government reactions are the same. There's a certain denial and censorship that occurs, particularly around cholera. Countries are very reticent to acknowledge that it is in fact a cholera outbreak and it's not just some kind of flu that's occurring. And censorship is frequently seen. Censorship of health workers who are reporting how bad it is, for example, in China, as well as in many other countries where health workers in Russia, for example, spoke out about lack of PPE and were shut down or arrested in some cases. Blaming others and closing doors. So in Europe, a lot of blame in Hungary and people from outside of the country bringing COVID into the country. Also, the common response in the early days of HIV, that this was a disease of foreigners and not a locally occurring phenomenon. Actions taken to appear to do something. The the issuance of lockdowns in Ebola of whole districts within the capital city in Liberia was justified because they wanted to send a message that this was a serious pandemic. The consequences of sending a message sometimes is that people don't have access to their livelihood, they don't have access to food, there's an increase in violence within the area that's locked down. And it's also arbitrary. People who have the ability to bribe their way out, who have the ability to leave early, can do so. So criminalizing exposure and transmission, we've seen that with COVID also. It's often something that leaders feel like they can put in place, but that isn't really usually shown to be very effective. Opportunism. So in the US, there were restrictions placed on abortion, access to abortion because of the COVID pandemic. This wasn't, fully justified. Also, the Trump administration repealed environmental legislation. And then finally, stigma and discrimination. So what we know is that what governments should do is recognize who are most disadvantaged, work with communities. If earlier in the COVID pandemic, leaders were working hand in hand with labor unions, with faith leaders, with marginalized communities and leaders from indigenous communities, with correctional officers to ensure that areas that we knew would be hit hard would have sensible approaches, we might have seen a different trajectory in those settings. It's easy to identify cruise ships and college dormitories as being places that people are at risk, and then to put in place fixes. But we really need to look more closely at the community and really try and understand what effective approaches are. So these are some of the comments and articles that I've written on pandemics and human rights. And I'm highlighting this because I think it's important also to mention that in my mind, and I testified in a case on immigration detention centers and COVID, and I was asked by the prosecuting attorney if I was an epidemiologist or if I was an activist. And my answer to that question was simple. I said, well, I feel as a scientist, I have an obligation to speak out about what is an effective approach and what isn't an effective approach. And that is advocacy, and that is activism, and that is part of science. And so I think for me, it's important both to be writing book chapters here on health security, journal articles, but also things in CNN, things in foreign policy, things in Think Global Health that reach a different audience, and that also need to understand the message. And I wanted to kind of come back to Susser's question, which is, what does an epidemiologist need to be today? What tools does an epidemiologist need to be effective? And I was inspired by this article called Neocolonial Epidemiology, which recounted a similar struggle to understand a role for epidemiology within a country with a lot of health needs and a lot of social and economic stratification. And I wanted to quote this one section of it, which is: an epidemiologic practice committed to the right to health should aspire to transform rather than reproduce the social hierarchies underlying such inequalities. And I think that's the challenge, is how do we use epidemiology to go as far as we can to transform global health, to transform societies into more equitable and healthier communities. And for me, part of that is to really look at these structures of power that codify stigma and discrimination, that structurally prevent people from being able to access appropriate healthcare and appropriate prevention measures. And you can look at these in a legal setting, you can look at these in a human rights framework, but these are the areas that I think by honing in and focusing further research, we can hope for change. And as a part of that discussion of neocolonial epidemiology, I also wanted to highlight how far we still have to come in global health in terms of addressing decolonialist approaches. We're still promoting tech vertical driven programs. We're still depending upon experts designing programs without an understanding of context, community, values, and culture. We're still defining global health priorities outside of the countries where those priorities should be defined. We're still using narrow metrics of outcomes and cost to determine success. We're still ignoring indigenous knowledge and privileging Northern voices in journals, advisory panels, donor agencies, and implementing organizations. We're still avoiding building adequate capacity and infrastructure, for example, manufacturing COVID vaccines in low and middle income countries. We're still avoiding recognizing and understanding what it means that people have a right to health. And so I think it's important in terms of thinking about alternatives, two pieces. One is recognizing complexity and not being simplistic. And this is where I think magic bullets often fail, is that they only address one aspect of the problem, but they don't encompass it all. And the other is that recognizing that public health's greatest successes have often been tied to human rights to health approaches. So looking at how a movement around the right to health transcends health into strengthening communities generally and can build upon other social movements. The challenges that we face in terms of climate change and health, in terms of all of the different possibilities of emerging viral and new pandemic diseases, makes us challenged to think of individual magic bullets for each one of these. And so thinking of a response to global health, which is about strengthening communities and strengthening our understanding of human rights, is a way to be more resilient in challenging any new global health challenge that comes along. And I want to speak specifically to the role of universities, because we're in a university, and I think universities have an important role as a different voice, as a different entry point than private donors, UN, governments. Students in universities can be engaged to think critically from local to global and across methodological disciplines to really examine what is a public health intervention. You know, in the work that I've done on prisons, often the most powerful approach to reducing HIV and TB vulnerability isn't narrowly bringing in HIV information or tests or screening, but it's about making sure that people who don't need to be in prison are released from prison. In a lot of the African prisons where I've studied, more than half of the prisoners are in pretrial detention. Many of those people are in for nonviolent offenses. Sometimes they can't get access to a judge and to a trial for months for a minor arrest for petty theft. And if you look at the cost of that, if you look at the failure to implement community-based service alternatives, a bail process, the cost in terms of public health, the cost in terms of lives is just huge. So in terms of global health education, it's important to critically examine our methods, our assumptions, our priorities, to use case studies to really look at the multifaceted ways in which global health needs to be approached and solutions need to be found, to examine the evidence to advocacy pathway. How do we articulate our findings and bring them into the world and be a part of the solutions? To really come back again and again to this question of who's included and who's excluded. And then finally, I put here humility. And I published a paper a couple of years ago called Apology and Unintended Harm in Global Health, advocating for more recognition of when mistakes are made and thinking through what the appropriate response is when global health efforts lead to unintended harm. So on the theme for this conference about research to tackle emerging challenges, I wanted to leave you with just a few thoughts. One is to put people first. One is to understand and engage with communities. Another is to increase attention to equity. And I put it here in parentheses, avoid low-hanging fruit. there's a lot of ways in which we might be able to find a solution or address a problem by looking at what the easiest way, who can we reach? But these often end up being ways in which inequities are magnified, and in which after achieving a certain level of success, people pack things up and go home and don't continue to try. Identify novel interventions beyond the specific discipline that we're in, and recognize that there are no magic bullets that can be deployed without a recognition of context, without a broader understanding of ways in which other forces may undo those bullets. And then finally, link the research to clear interventions. And if you focus on human rights, you're creating interventions that will be durable, that will work across specific issues and specific diseases, and which can be sustained over time. Thank you so much. I've included my email address here if anyone wants to reach out to me and ask any follow-up questions after this session is over, or talk about more of my research. I'm more than happy to engage on that. And with that, I think we can move to Q&A as well, if there are
any. Thank you very much, Dr. Amon. So we do have a few questions. So I'll start with, one of our attendees asked, I wonder what your thoughts are on the importance of public opinion or individuals' education versus policies and laws in suppressing or eradicating a certain disease, and how that may vary with how a developed country is. It's clear to me from this last year that the public's willingness to work together is essential for this, but what are your thoughts on this dynamic between education versus laws?
Yeah, so it's a great question. And it brings me back to my first work in guinea worm, because guinea worm had a very fragile life cycle. And so there were ways in which you could go in, you could spread a cloth filter that people could filter their water with, and you could break the cycle of transmission within a year. And when I was in Togo, we saw 50% declines in the number of cases each year that I was there. And that was phenomenal. And it didn't require necessarily everybody in the community understanding everything about the disease, everything about the life cycle. It was a great technology that worked. But at the same time, I think there's also limits. And sometimes the limits are where the biggest challenges are. You're able to reach a certain amount of the community, but there's a part of the community that either is ignored or it actively resists. And I think that phenomenon can result in things bouncing back, right? And that's what we're seeing right now with COVID to some extent. We're seeing some people getting vaccinated immediately, some people waiting and seeing, and some people who are, basically opposed. Will we be able to drive the number of cases down with some percentage of the population not wanting to get vaccinated? I think it would be a big challenge. And I think what we'll see is a very uneven picture in a number of months where there continues to be outbreaks. And this, this certainly was the case with measles, for example, in Orthodox Jewish populations in New York, with the Somali community in Minneapolis, where you had specific communities that were resistant to vaccine. And when the virus was introduced, the cases exploded.
Thank you. So as a follow-up question along the lines, so during your talk, you said that it's global challenges are complex, and it's sometimes we only look at solving a small aspect of it, and kind of which isn't effective because you're missing the total complexity of it. So how do we what is one strategy to make sure you address the complexity? Does it have to do with involving a diverse team, or is it more like a systematic change from lawmakers?
Yeah, I think that's a great question, and it's a challenging question. If you look at a country like Yemen, which has had 2.5 million cholera cases, um, there's a conflict going on. There's an enormous challenge in working in that country. Cholera is something that can be solved. Cholera is not something that has to continue forever. Um, it's much harder to control after it gets to a certain scale. But initially, you can treat cholera effectively. You can end cholera epidemics effectively. Another example is Venezuela, which has had a political collapse, which has had a resurgence of a wide range of infectious diseases that have spilled over into the bordering countries. Those are situations where you need public health voices calling attention to these issues, but you also need political solutions. And in global health, generally, that isn't uncommon. You see the UN Security Council, when it's talking about Venezuela, they also talk about the way in which Venezuela is a threat to the region because of uncontrolled malaria and because of uncontrolled Zika and dengue. And so the issue is that by reaching out, by being an expert voice on the importance of a public health approach in places, you can often partner with and have a kind of a coalition approach, both with people at the community level who aren't public health experts, but also at a global level who have an interest and desire to see the protection of communities and stability of states.
Thank you very much. And there's just one last question. What are your thoughts on fair access to COVID-19 vaccines? How can we achieve it? And why is it a struggle?
Yeah, I mean, the challenge is we have a kind of a global intellectual property regime that protects companies and protects discoveries, despite the fact that there's a lot of public funding for the science behind these vaccines. And there's a tension between, when do you say this is of such incredible importance that we need to break that regime and create an exception to it, and create a mechanism by which there can continue to be science and innovation, but we can address what is an unprecedented global crisis. And I think so far the attempts to do that, the COVAX mechanism, for example, where countries are contributing vaccine, have been vastly inadequate. I think we need to think on a different scale. And some of that is starting to happen. Moderna has talked about developing a factory for manufacturing vaccines abroad. There's a Professor Hotez in Texas at Baylor has also talked about a lower cost version of a vaccine that can be more widely available and not patented. So I think there's a mechanism, but the time frame for it isn't quite in sync with the need. We need to be acting now. We need to be asking of the US government, why we're holding on to AstraZeneca vaccines that we could be releasing right now into communities where they need it. Because it's a slogan that we're not going to be able to get past this pandemic unless we're all vaccinated, but it's also a reality. We're just not going to move on unless we're all together on this.
Yeah, that's very true. And again, thank you for your talk, and thank you for taking your time to speak to all the graduate students.
Absolutely, and I think this is a great opportunity for you all to kind of look at this question of emerging challenges, question your approaches, your methodologies, your collaborations, your partnerships, your activism. And I would just applaud you all for the work that you're doing. We need people from every science and every perspective in every country in the world to be finding the solutions to all of the global problems we face. So thank you again.
Yeah. So I just wanted to also thank our attendees for joining the keynote speech. And please join us for our first oral presentation at 11 o'clock. Thank you.